All right. I want to thank you all for coming here today. I hope you're enjoying the free food, and that's not the only reason you're here. I hope we have a week full of a lot of lectures and presentations that we can learn a lot this week. So this is National Primary Care Week. It is sponsored here by the AHEC office, and each speaker is also co-sponsored by a club here on campus. We have two speakers today that will be on a panel that we'll be able to ask questions to at the end of their presentation. The speakers are co-sponsored today by the American College of Osteopathic Pediatricians Club and the American College of Osteopathic Family Physicians organization. So my name is Giovanni Croslin. I am your treasurer of your local secretary of your local pediatrics club. Let's keep the roles straight here. I will now turn the time over to Michelle Hamilton. She's going to introduce our first speaker, and I'll let her go from there.
Hi everyone. Our first speaker is Dr. Wesley Ryle. He's currently at Kirksville Family Medicine, and I'm a physician here at AT still. He graduated in 1999 from Truman and then did his MD at the University of Missouri Columbia School of Medicine. He did his residency at the Eisenhower Army Medical Center in Augusta, Georgia, and he was honorably discharged from the U.S. Army in 2010 as a major. And he's been at Kirksville Family Medicine since December of last year, and I'm going to turn it over to him.
Thank you all for having me here. I appreciate the opportunity. I was asked to come talk with you all about family medicine a little bit and kind of share my story with primary care and how I ended up here, and then we'll kind of take questions if anyone has any questions about that. I guess first of all, like many of you, as I was growing up, I knew I was really interested in science, and I had a long interest in medicine, wasn't exactly sure what I wanted to do. Actually, before I even came to med school, I was actually interested in doing general surgery. I thought that's what I wanted to do. Essentially grew up here in Kirksville, and lived here, kind of grew up in kind of a rural setting. Went to Truman, knew I wanted to do medicine, thought I wanted to be a general surgeon, and then went to University of Missouri Columbia for med school. That's kind of where I diverged off from my plan to be a general surgeon. I realized pretty early, just doing like you all do, we did some early clinical before even third-year rotations, but just doing some early clinical experiences. Started looking around, and I started talking with the surgeons there and the surgery residents, and I'm looking around and I thought, my gosh, these people don't seem very happy. You know what I mean? And I think part of it was just the local institution, not so much, I look at I see our surgeons here and they seem much happier than the ones at University of Missouri, and I don't know why that is. Obviously it's a small group here, but I just felt like they weren't really getting along well with each other. The residents all, hated their existence basically. They were just miserable. This is all way pre-80-hour work week, and so they were just getting killed, but still had a lot of interest in surgery. And then during my third-year surgery rotation, what was really kind of the nail in the coffin is we were doing this big esophageal resection case where we were basically going up through the abdomen into the thorax and bluntly dissecting around the esophagus. It was one of these huge they don't do stuff like that here, but it was like a big 9-hour case. And for those of you who know me, I like it warm. I like it hot, like 110 degrees is great. So I don't get along well in operating rooms. And I thought, I've been standing here for 8 hours. I'm this deep into somebody. And I realized at that time for sure, I was like, I do not want to do this for the rest of my life. So for me, I knew I always wanted to be in a rural location. And actually, I had a lot of plans to even be somewhere more rural than Kirksville at one point. So in some degree, that sort of guided what I did, because a lot of the things that my problem has always been I've loved everything and I've been interested in everything. To some degree, geography dictates what you do. You know, if you want to be a pediatric oncologist, you can't work in Kirksville. I mean, there's, you know, or a more rural area. So in that regard, geography played an important part of what I decided to do. I had actually really been interested in med peds. I don't know, are any of you all familiar with med peds programs? I don't know if are there AOA med peds programs? I don't know if that's, it's sort of a specialty that's kind of waxed and waned through time and had variable popularity. But med peds is a combination of, it's a 4-year residency where you do internal medicine part of the time and pediatrics part of the time. So the other group of people when I was in med school that were not particularly a happy bunch was the University of Missouri OBGYN program. And they were not, it was probably the most feared rotation in all of med school, because no matter what, you just couldn't stay on the good side of the residence. So I actually had a little bit of fear of OBGYN in residency, and was really wanting to do med peds. Now, go back to 1998, I signed up with the military to be a doc in the Army, and they were going to pay for my med school at University of Missouri, and I did that before I even matriculated to med school. And so at that time, and I think it may be a little different now, but at that time you were expected to do a military residency. The only way you wouldn't get selected to do a military residency, which by the way they offer fantastic residencies, is if you didn't match with a military residency. If they said basically we don't want you, we're not selecting you, or you wanted to do something that they didn't offer, like radiological oncology, to be a type of doc that they didn't have a training program for. And if they said, yeah, we want to have that kind of doctor, they would let you do a civilian deferment. So anyway, they did not offer a med peds program, and they said, well, we're not really, we kind of would like you to do internal medicine or pediatrics. And I said, well, I want to see kids and I want to see adults. I wouldn't be content just seeing one or the other. So I went into family medicine and thought, well, I'll take the OB that comes with it. Now, during residency, I learned to really love OBGYN and really enjoyed it, delivered a lot of babies. We actually had that was a very big part of our training program, was obstetrics. And delivered a lot of babies while I was in the military and residency, and then beyond, we were expected to continue to do OBGYN. So that's sort of how I got, to become a family physician. And so it was sort of, I knew I wanted to do primary care after I figured out I didn't want to be a surgeon. And I knew I wanted to see kids and adults, and med peds didn't work out. So I was sort of a de facto family medicine doc, which now looking back, I couldn't be happier, and I wouldn't have done it any other way. I had a little bit of a non-traditional route going through the military. When I signed up in 1998 for the Army, I was single. I come from a family where everybody's served in the Army. My grandfather was an officer in World War I, and so I was going to jump out of airplanes and be this high-speed special operations doc and do all this cool guy stuff. And then a lot happens between college and then getting out of med school. And then in the meantime, I got married, had kids, and I figured out I didn't want to do all this cool guy stuff anymore. Like, I just wanted to be home with my kids and, not get shot, not get killed. That was sort of my main objective, is be alive for my family. So anyway, went to Augusta at Eisenhower Medical Center, which is a large medical center with, it's a 12-story hospital with more specialists than you can shake a stick at. That kind of hospital, and had a very broad-based training in family medicine, and then was in the served as a doc in the military for a few years, and then came back to my hometown. My wife and I figured out that, she's from Kirksville as well. We met in high school, so we're high school sweethearts. And we figured out that we didn't want to go someplace more rural than Kirksville. We just wanted to come home and raise our family here and be with our parents. And that's how I ended up in Kirksville. I decided I'd had enough of the military. I really enjoyed it. I loved being in it, but I kind of was done with that and wanted to just have a quiet life and hopefully live the rest of my life in Kirksville and die here. And so that's kind of how I ended up back in Kirksville. Any questions about any of that, or the military, or so? Janet, was there anything else in particular that's sort of just a little bit about my story of how I ended up here? And I don't know if there was anything else that you were, as far as the thrust of the presentations, or?
I guess one question could be, is there anything you'd change about your path?
Anything I'd change? No, I don't think so. I mean, I feel so lucky to be where I'm at now, and I really enjoy what I do. Along the way, like I had said, had I had the opportunity to do med peds, I would have done it then and not realized how much fun stuff I missed out on doing the OB. And again, I had a lot of fear and really just detested OBGYN in med school because it was such an unpleasant rotation for all of us. It was just sort of a malignant program. But then, like I said, I ended up loving it, loved delivering babies. I don't do that anymore, mainly because of the hours. So when I moved back to Kirksville, I finally stopped providing routine obstetrical care, really because I had kind of gotten tired of coming in at 3 in the morning to deliver babies, to be honest. And we live in a town with a very large number of OBGYNs for the population, so we're hardly underserved, and I just said, I think I'm done with this. So no, to answer the question, I wouldn't do anything different. I feel very blessed to have kind of meandered the route that I did. Really loved my time in the Army. Wouldn't trade that for anything, but what I tell people is I wouldn't change anything, but if they said, and I miss it a little bit every day, but if they said, hey, would you come back in? I'd say, no, I'm kind of happy where I'm at, so. Yes, ma'am.
Was there a reason, maybe outside of just wanting to get away from home, that you decided Mizzou instead of ATSU?
Well, I love Columbia. For those of you who haven't been there, Columbia is a really fantastic town. I mean, it's a really fun place. Like Augusta, that has about 350,000 people, has way less to do than Columbia, which is actually a much smaller town. And I just, I went to several folks, and I just really enjoyed it there. The curriculum was very progressive. I think in 1990, I think it was around 1997, they actually went to like the problem-based curriculum, which I don't know if any of y'all are familiar with that. But they had a very progressive curriculum, very strong program, and I just kind of went where I thought would be best for me. But I definitely looked at going here. But the other part of that is definitely a big part of it was, like I said, my wife was here, I was here. Neither of us had ever really kind of made that journey and left home. And sometimes it's it's good to just get a little further away from the flagpole, you know what I mean? And especially we had just gotten married as we were leaving college, and we kind of wanted to just kind of strike out on our own a little bit. And that was probably one of the major things, so. Ma'am?
Can you talk about the difference besides the peds part between internal medicine and family medicine? Besides the peds part, and that you're not in the hospital more? So
a lot of that is going to depend on where you train. But in general, so obviously other than the peds and the OBGYN part, which honestly, and some of that's going to depend on your, like I said, on your, where you do residency, but my experience has been most places, internal medicine does very little, anything that's OBGYN basically kind of gets referred. The big thrust is, in my opinion, hospital work versus ambulatory care. And if you just look at the numbers, the vast majority, so this being primary care week, I think it's important to point out that the vast majority of IM trained residents go into specialties. That's just, I mean, that's just the facts. For a lot of people, internal medicine is a path to a specialty, and it's the gate to pretty much all the non-surgical specialties. You of course can do ambulatory general internal medicine, which is an amazing field, and you know, requires a very strong general skill set. A lot of people banter about that family medicine is a more holistic kind of, than internal medicine, and I don't buy into that. It's kind of, I'll occasionally get, you know, being at a DO institution, occasionally I'll hear about how DOs look at whole patients, which I don't buy into. It's, you know what I mean? It's not like I was trained, well, oh, that's, you know, that's just a lady with cirrhosis and there's nothing else going on. So, in the same way, I don't buy into that family medicine physicians are any more holistic than internal medicine docs. I think there are good internal medicine docs who look holistically at the whole people, and they're bad ones, and I think they're bad family medicine docs who don't look holistically at people. And so that really sort of the inpatient. And then there's just no doubt in general medical problems, there's more training there. You know, there is at most places. Now you have to, again, you have to compare, you can't compare one internal medicine program against a family medicine program somewhere else. But given programs of equal training, the bottom line is for those adult problems, your internal medicine doc in general is going to come out of residency with a stronger skill set just because they've spent more time with those problems, but not as broad-based of a skill set. Sir.
Being like family med, practicing here in Kirksville, where there isn't many specialists to refer to, how do you actually find so many doctors that you can refer to, especially in the specialty area?
So the question is how I find docs to refer to, or sort of how I make decisions on when to refer, or so that's a big challenge in primary care here, is getting folks to specialists, and that's going to depend on specialty. Now, finding docs to send them to, for most of my patients is not a problem. You know, most of my patients are not going to, it's not going to be an issue to get them an hour and a half to Columbia or an hour to Quincy. Certainly we do have a few patients that just don't have access, and for most of those folks, people who don't have an access to a vehicle, we can get them on a NOTES bus or something to get them there. Now, finding the docs is easy because that's, you know, people advertise themselves. Medicine's become a relatively competitive field, and it's very easy to find people to get them to. The problem that we'll have with some specialties certainly is coverage. So for those of you who haven't gotten into this stuff yet, you know, we have a large Medicaid population here. Those people are definitely at a disadvantage when it comes to finding care, especially on the adult side. A lot of kids have Medicaid, and it's pretty much anyone who sees kids for the most part sees Medicaid, certainly, you know, around here. Adults is a different, it's a completely different thing. If you have an adult with Medicaid, there are a lot of docs that won't see those patients. So the challenge here is really the scope of care that you have. For example, psychiatry is really the case study in that. So we're very underserved psychiatrically here, okay? Even outside of here, there are a lot of docs that won't accept Medicaid, and of those that will, you're talking about months wait lists to get someone in. So as opposed to when I was in the military where I didn't realize it at the time, but I had very easy access to psychiatry. I could get someone in the same day if I just said, hey, I think this person really needs to see you. I can't do that here. I have to be the psychiatrist, unfortunately, and that it may horrify Dr. Moore, but I actually even, to some extent, and I'm sure he's in the same boat, am forced to play child psychiatrist with some issues simply because when you get into child psychiatry, a lot of psychiatrists won't see kids, so you get into all sorts of issues. So that's the challenge, is just accepting accepting a broadened scope of care that you may not be comfortable with. But I'll turn it over to Dr. Moore.
Thank you, Dr. Ryle. It is my privilege to now introduce our next speaker, Dr. Brett Moore. Dr. Moore is a pediatrician here in Kirksville, practicing out of Northeast Missouri Pediatrics Clinic. Dr. Moore is, I think, a hometown. Yep, graduated from Truman 2003. Graduated from KCOM in 2008. He then went on to do his residency in both family and pediatric medicine at the University of Missouri Healthcare, right?
Yeah, but it wasn't family medicine, it was just pediatrics. I did 1 year in family medicine.
Okay. All right. Well, there you go. All right. So please join with me in welcoming Dr. Brett Moore.
Can everybody hear me okay? Like you said, my name is Brett Moore. I did 1 year in family medicine, just to clarify, and then decided I really liked kids a whole lot more than dealing with the adults, so then I switched to pediatrics. So first of all, is there any questions in general that you guys have about pediatrics or practicing pediatrics in a rural setting right now? If not, I can kind of just talk in general a little bit about kind of what I do every day. So I'm a general pediatrician, and being in kind of the rural setting, I do tend to do a little more probably than some of the other general pediatricians in some of the bigger cities. Kind of what Dr. Ryle alluded to. Not a lot of specialists just around here immediately, and a lot of the specialists that we have in other cities, they get pretty busy. So we end up seeing quite a bit and doing some of the specialty care. There are still a lot of things that we still have to refer for specialists, but I tend to do, and my partners in our practice tend to do probably a little more, again, like I said, than some of the general pediatricians in the bigger areas. Another thing that I tend to do, not I tend to do, but our practice tends to do, we do a lot of baby medicine, so we're in the nursery seeing kids. We also do inpatient peds, and again, in a bigger setting, say like St. Louis, Kansas City, even in Columbia, some of the doctors there in private practice in pediatrics don't even go in to see kids in the nursery. They don't attend C-sections and help those babies, and a lot of them don't even see patients in the inpatient setting. So being in the rural area, I get to kind of do a little bit of everything, which is nice, because you get to keep up on all the information on every level. So that is nice. That's one of the benefits I feel like to being in the rural setting, in the rural community. So what I do, I see patients in an outpatient setting, and then either before or after clinic, then I'll see the patients that are either in the hospital, or if the baby has been born, seeing the baby afterwards. If there is a C-section, like if it's in the middle of the night, then I go in and I attend the delivery. People always say, do you do the C-section? No, I do not do the C-sections. I just catch the baby when the baby comes out and make sure the baby's okay. But if anybody wants to know, pediatricians do not actually do C-sections. We just get the babies after the C-section. So, but one of the things that I really enjoy is the neonatal medicine and working with the nursery. So that's a lot of fun. So again, another benefit of working kind of in the smaller town setting. As far as education, went to KCOM 4 years, and then did residency. In pediatrics, residency is for 3 years. And the first year is that intern year, a lot more inpatient setting, and then the second and third year, less inpatient, but still having a lot of focus on inpatient setting with your rotations that you do. You rotate through the neonatal ICU, your pediatric ICU, you get to rotate with a lot of the specialists, whichever specialist you want to spend more time with. Sometimes electives allow you to spend more time in that certain setting. So it's 3 years then for residency, and then if you do want to specialize further in pediatrics, you can specialize in almost any setting like you would be able to if you went into internal medicine as well. So in endocrinology, neurology, rheumatology, physical medicine, and rehabilitation, pretty much everything, you then would be able to go and do a fellowship if you would like to do so. Usually those anywhere between 1 to 3 years, depending on which specialty that you would like to do. So if you do go into pediatrics and decide you want to specialize a little more, you can do that. There are a lot of options out there with pediatrics. And then usually if you do a fellowship, a lot of times those people end up going on and practicing more in an academic setting, because that's where a lot of those people are going to see a lot of the referrals are in academic settings. So if you do decide to go and do a fellowship, say like in GI or something like that, then you end up setting around probably usually in the academic setting to see a lot of patients. So for people that like the big cities or the bigger cities, sometimes the fellowship's the way to go. They can set up with an academic university. So anyway, so that's kind of just a little bit of kind of the education process that we have in pediatrics, very similar to what you would see with internal medicine and with family medicine as well. So any questions about the training portion of it? Yes?
What's it like transferring from one residency to another?
Sure. So the question was, how difficult was it to transfer from one residency into another? And when I first started medical school, I always thought that, boy, once you start a residency, you know, you're kind of streamlined, you can't really change. You can change. It happens quite a bit, a lot more frequently than I had first thought would happen. For me, it worked out pretty easily because family medicine at University of Missouri and Pediatric University of Missouri, they're pretty nice to each other and they work well with each other, and the fact that it was in the same university setting made it really easy to kind of change. I talked with the residency director of both family medicine and pediatrics and kind of explained what I was doing and why I was doing it, and they were pretty good about allowing the switch to happen. Now, if I was to switch to a different university or to a different residency area, then I would have to then re-enter a match and do the whole match process to then go into pediatrics. And if that were to, and if I had to do that, then I'd have to go on, you know, interviews and do that whole thing all over again. I did get about 6 months credit for pediatrics from my family medicine residency. So I was only in residency for pediatrics in that residency program for about 2.5 years because I got 6 months credit for family medicine. But your contracts are usually for a year. So at the end of that first year, you're not obligated. If you have really decided and, you know, did some soul searching, really feel like that's not what you would like to do, you want to do something else, you can. The problem is you just have to redo the whole match process sometimes. Okay. Any other questions about education? Yes?
What about like pediatric neurosurgery? So there's the initial rotation and then specialty, and then would you have to do like a surgery rotation as well?
So for neurosurgery, you'd have to then actually just do neurosurgery residency.
Okay.
I believe that's 7 years for the neurosurgery residency, and then if you want to do a fellowship in pediatric neurosurgery, I think it's another year or two maybe after that. So that would be something sort of like orthopedics, where you would go in to do the surgery residency first, and then you end up doing the fellowship then after that. It wouldn't be doing peds and then doing peds neurosurge. You would do neurosurge first and then a fellowship in pediatric neurosurge. Okay. Any other questions about, oh, yes?
Just kind of generic question, maybe you kind of alluded to that, of why you chose pediatrics. You know, often when, for example, I'm looking into what I enjoy doing, I say, well, I might enjoy kids, but hey, I hear that you only see red noses every day, and I hear that nurse practitioners are going to take over my job, and I hear that I'm going to get paid the lowest of every profession. I mean, I'm just kind of generalizing. Did you consider that when you were thinking about this?
Those are good questions. I took everything into consideration whenever I decided to do what I was going to do. The first would be to make sure that I was going to be happy and love what I was going to do. The second was to make sure that I'd be able to have a family life as well as enjoy my professional career. Why I decided to do pediatrics. Family medicine is great. I don't want to put down family medicine or anything like that. Family medicine was great. It's just how I guess I was built. And everybody knows that they have their own specialties of what they like to, what their interests are, what they feel like they're really good at. And with family medicine, there's a lot of chronic care, a lot of elderly care, especially in the area that I was doing my rotations through and that I did my clinic through. And for me, it just didn't click with me very well. Whenever I saw a kid, it was like a vacation, honestly, from seeing the rest of the patients, and whether that sounds good or bad or whatever, it's just kind of how it was. I would look at my schedule whenever I came in and I saw all the birth dates, the years were before, 1950, and not that that's old. I'm going to get in trouble here now. But whenever I saw like a kid that was, that was like 5, again, it was like a vacation for me. I'd go in and see whether the kid had a cold or whether it was a well child check. It was so fun. I go in and I talk to them and they talk back and they have a conversation and they're telling you about this. I remember this one kid had a cowboy hat and cowboy boots and he was so proud of him. He was talking to me about it and it was just fun and I had a good time and it didn't feel like work. And it made me really start thinking about what I was doing. And I was fortunate enough that my first year in residency, my first 3 out of the 5 months were pediatric rotations, and I really had a good time on there, and I enjoyed myself a lot. And I thought, if I came home every day after doing family medicine, I'd feel really run down, and it just was just a different mindset. And my wife noticed that after I had changed that I was a lot happier, and so it was a happiness factor of why I decided to change. It wasn't a money factor. Though, are we the lowest paid? I don't know, we're the lowest or maybe second lowest. I really don't know which one we are. It's not high. But the other thing is, you're going to be able to pay off your loans and you're going to have a comfortable living. And to me, that's all that was really important. I didn't need to have a big car or a big house. I just needed to pay off my loans and be able to support my family. And I'm able to do that. And so for me, the money wasn't a big reason. So for me, it was more the happiness factor, what I felt like I enjoyed. And the more you enjoy something, the more you want to learn about it and read about it, and the more you retain. And so me to stay in family medicine was not going to be fair to me. It wasn't going to be fair to the patients. And so that's why I decided to go ahead and switch. Okay. No problem. Any other questions about education, switching, residencies, anything like that? Yes?
Kind of on a different tangent, but something I've always worried about with kids is having to interact with parents and completely depend on the parents more than the children, because I really like working with the kids when I work in the pediatric clinic.
Sure. It doesn't have to always be up to the parents every time. Sometimes you are, of course, with especially with the toddlers and the babies. Of course, you're going to get a lot of that history from the parents. I don't know. I guess I hadn't thought about it as being a bad thing. I grew up in the house of my dad's a veterinarian, so none of the patients ever talked to him. So I guess I was kind of used to that. But as far as the standpoint of dealing with the parents can be the best part or the worst part of the visit sometimes, depending, because sometimes the parents get really frustrated because they have a sick child and you offer as much as you can. Sometimes they feel like maybe there should be more, and so you have to kind of talk to them a little more, and that can be kind of frustrating from the fact that sometimes I don't think that they think you're doing all that you can, even though you're trying. So sometimes that can be frustrating from that standpoint, but for the most part, in the majority of the visits, they really appreciate all that you're doing, and sometimes the education that you can provide to the parents and making them feel better about things, or even if it's something that may be really wrong with the child, and telling that you're going to help them get through this and you're going to help them, get referrals and kind of follow up with them, they're very appreciative. So in a way, they can also be the most rewarding part of the visit too. So it's kind of a double-edged sword with the parents. But I understand the concern, but they can, and for the most part, are a benefit and can really help with each visit. So.
I guess especially with child obesity, it's not the
Sure, and you have to be kind of delicate about how you're talking, especially with obesity and that subject, because you don't want to act like you're being, you don't want to act like you're accusing them of something or being a bad parent. It's a touchy subject, and it's probably one of the biggest problems that we're seeing in pediatrics right now. You have to approach it from the standpoint of saying, your child would, and I always show them charts of saying, where their height is, where their weight is, where their BMI is. I try not to, and of course it goes without saying, try not to use the word like fat or anything like that, or even obese, honestly. You just talk about a healthy weight and kind of where they are and problems that can happen down the road if things aren't checked into and changed. And so again, you just talk about, okay, what kind of things is the child eating, and trying not to go, what are you feeding your child? Trying to go from a different standpoint so that it doesn't sound as accusing. It can be hard, and no matter how you put it, sometimes some parents will get offended, and that's just kind of how it is. But again, you try to focus on that you're helping the child and you're focusing on the child, and what you're doing is really for the child. And sometimes you come in from that standpoint, as well as kind of being gentle about how you're giving the information to the parents, it'll work out okay. Yes?
Along the lines of parents, I read an article recently about a doctor on the East Coast who prescribes Adderall to children in low-income homes because they have no parent supervision and they're doing bad in school. He doesn't necessarily think they have attention deficit disorder. Do you find problems with the way parents are raising their children and they come to you requesting some solution for their child's misbehavior, anything like that?
So the question was my opinion on how the parents are parenting and whether that affects how the child's behaving and what to do about that. So that's, again, another touchy subject. The question is kind of environment versus learned behavior versus genetics. There are a lot of people that are out there that are diagnosed with ADHD and on stimulant medication that probably don't need it. But there's also a lot of kids out there that have ADHD that are on a medication that would help them. So it's a case-by-case situation. I always try to talk about behavioral strategies before doing stimulant medication. Because there's three main if a child really has ADHD, there are three main things you look at. You look at help with the school, medication, and behavioral therapies and counseling. And so I try to hit the other stuff first before going to a stimulant medication, doing questionnaires, finding out what exactly is the child's problem. If I do have concerns about the parenting situation, there are, and somebody just kind of started up some parenting classes around the area that I try to refer people to. So I try to go and look, and if I do feel like there's a problem with how the parents are handling the situation, trying to focus a little bit on the behavioral modifications versus going ahead and starting them on a stimulant for that. Make sense? Okay.
I can interrupt for just a minute.
Yes.
We'd like to get Dr. Ryle back up here. I'd like to say thank you to both of you. If you want to come on up, we've got a few more minutes for questions, but on behalf of AHEC and the clubs that are sponsoring these, have a little goodie bag for you.
Thank you so
And there's a
much.
box with dinner too, so.
Appreciate it. Appreciate it.
But at any rate, if you guys would like to continue the question and answer, that'd be great. There probably are a few more. Thank you.
Yes.
I kind of have a generic question for both of you because you both kind of touched on it. How do you know when you're in a rotation or a residency, maybe even one that you thought that you're really going to enjoy, but then you realize that it's not for you? How do you know if it's necessarily like the type of program that you're in or just the hospital or location that you're in? Does that make sense?
No, so you're asking how do you know it's the actual job that you like or if it's the setting that you like?
You said family medicine. How do you know if, what made you decide, okay, it's not just the hospital that I'm in, it's actually I need to switch from family medicine?
That's kind of something that I had to look at inside and kind of go through pro-con list and just in the end, it was just kind of how I felt. I knew in my heart that that's what I really enjoyed doing versus the other. And through rotations, you're probably going to go through and like a lot of what you see and a lot of what you do. Also kind of take a look at your rotations and say, did I really enjoy the rotation for the medicine aspect, or did I enjoy it because of the people that I was surrounded by? Because a lot of times if you have a really good rotation, maybe because you had a really good mentor or a really good doctor that you're rotating with, and you kind of have to decide whether you like that rotation again because of the medicine or because of the people you were around.
That's a good question, and it's hard, and kind of like what we were talking about. I think if it's something you think you're interested in, but you lose interest in it when you're in your rotation, I think it's worth doing an out rotation somewhere else and saying, hey, maybe it's just this, you know, if you are somewhere where you have 3 docs in that field, you know, maybe just 2 docs in that field, and that's your rotation. Just your in of 2 docs is not adequate to really get a feel for what it's like, and maybe they're the 2 most unhappy docs in that specialty in the world, and you may go somewhere else and it has a completely different feel. So if it's something you think you're interested in, I'd really encourage you to, even if you have a bad experience at one place, go somewhere else, because every institution has its own culture.
I have a question for you. So with pediatrics, are you trained to do the circumcisions? Is that something that the OBs do, or is that a blended?
It depends on the residency that you train in. I know some residencies where they try to get the peds people as many circs as they could, but the OBs did it. Where I went, the OBs did not do any of the circumcisions. It was all the pediatric and the family medicine people that did the circumcisions. So it really depends on the residency that you train in, whether or not you're going to get a lot or any circumcisions.
And it also depends on the institution, like who's going to be that you're linked in with, who's going to be doing that procedure.
Sure. I mean, it kind of depends on just, again, the setting of what's usually happening in that academic setting. Something that if you were to do rotations, kind of ask the residents that are there, you know, whether they get to do them and how often they get to do them. Okay. Yes.
A lot of us are going to be doing rotations here soon, this next year. And Dr. Rowell, you mentioned that you had a rotation OBGYN that you feared a lot, but you came out with a good experience. The question I have is, what advice do both of you have on some of us students that, for those tough rotations, to turn them into good experiences?
I guess from my standpoint, a tough rotation for me usually was because I didn't have as firm a grasp on some of the material, and other times it was because of time factor. I guess always take a look at, you know, why you feel like it's a bad rotation. Is it something because you're just lacking on the knowledge and you need to brush up? Then just read as much as you can to kind of fill in the gaps on some of your knowledge. If it's because of a person and a conflict from that standpoint, seeing if you can be in a rotation with maybe one of the other attendings. I would say for me that was probably 2 of the big reasons why I was kind of worried about a rotation.
Yeah, I don't really have anything to add to that. I think just always look at, you know, if you know what you want to do, you know, think, if nothing else, what can I get out of this rotation that will help me with what I'm planning on doing? And I think, you know, there's some overlap with all fields, and you'll always be able to get something out of it. And just keep a positive attitude, try and have fun, enjoy seeing patients.
Yes.
In the field of pediatrics, do you see yourself being in a hospital setting for your career, or do you foresee maybe being in a private practice? I'm not too familiar with pediatrician as far as the economics of that, as far as, is it reasonable nowadays to start a private practice in a group of pediatrics, or is it just along the lines of any other professionals pushing into hospital employment?
So the question is, am I going to stay doing hospital work, or am I just going to do it? I don't foresee Kirksville getting to the point where there's hospitalists for pediatrics, so I will probably always be in the hospital as well as the outpatient setting. Again, if I were to move to a big city, I would probably end up just doing outpatient pediatrics and not doing the hospital medicine, because they have hospitalists in those settings that take care of them. And if I really wanted to and I could push for it, I could see patients in the hospital. But here in Kirksville, there will always probably have the rotation where we're seeing patients on in the outpatient setting as well as seeing them in the hospital. In a big area, you could probably decide and choose what you would rather do, whether you want to see both inpatient and outpatient, or if you just want to stick with the outpatient, or do you just want to stick with inpatient and be a hospitalist. It's in a big city, you have more options for that. In a smaller area, you're probably going to be doing both.
Thank you.